Hello, I'm Viviene Temple from the University of Victoria on the west coast of Canada. It is my honour to present the G. Lawrence Rarick Memorial Lecture. My lecture is entitled Steps and Stepping Up, Special Olympics Program Responses during the Covid-19 Pandemic. At the outset, I want to especially thank staff from Special Olympics International, Special Olympics New Zealand, Special Olympics British Columbia, and volunteers and athletes from my local Special Olympics Victoria for their input for this presentation. The coronavirus pandemic already counts among the greatest worldwide crises and has been and is an extreme challenge not only for our health systems but for society as a whole. Among many facets of life, sports and sports-related activities have been heavily impacted. In this lecture, I want to share how Special Olympics has stepped up to these challenges, as well as things that we need to consider as we transition out of the pandemic. Before we begin, I wish to acknowledge with respect the Lekwungen peoples on whose traditional territory the University of Victoria stands. As I was preparing for this presentation, I wanted to know more about Lawrence Rarick. I found that he was born in Stockton, Kansas in 1911. The youngest of 3 children, after high school he attended Fort Hays State College, where he earned 2 undergraduate degrees. And after teaching physical education and science for 2 years, a Master of Science degree in chemistry. He was thinking about entering the health sciences and successfully applied for both a PhD program and into medicine. Fortunately for our field, he chose to pursue his PhD at the University of Iowa with Charles McCloy and W. Tuttle, where he focused on both the biological and behavioural aspects of varsity athletics. His first academic appointment was at the University of Wichita, and he married his wife Mary Alice in 1939. He moved to Boston University, where he was assigned to teach undergraduate and graduate courses in motor development. This he credited with changing the course of his professional life. Like many young people at the time, his career was interrupted by the Second World War. Assistant Professor Rarick became Lieutenant Rarick, a communications officer with the United States Naval Reserve, and he served in the South Pacific. He established an extensive research program at the University of Wisconsin, focusing on children's growth and motor development, with a particular focus on children with intellectual disabilities. His final academic position was at the University of California, Berkeley. He was recruited by a retiring chair who said at the time, "He is not only the top authority in the field of motor development, but almost certainly he is the finest scholar in physical education in the United States today." I also read several of Dr. Rarick's papers related to physical and motor development of children with intellectual disabilities. I was particularly struck by this comment in his 1960 monograph on the motor characteristics of children with intellectual disabilities, which he completed for the United States Office of Education, because these comments from 60 years ago are also applicable today. He concluded that children will benefit from well-organised and patient instruction, that this will result in improvements in their gross motor skills, which in turn will provide the foundation for healthful and meaningful experiences. Something I didn't know, and perhaps the most apt given the content of this presentation, was that Lawrence Rarick was on the first board of directors of Special Olympics. The COVID-19 pandemic has disrupted the world, disrupted our health and well-being, our ability to go to school and work and see our loved ones. COVID-19 has affected travel, restaurants, conferences, exhibitions, and musical and sporting events. The personal and economic losses have been enormous. I'm sure you can think of many ways the pandemic has affected you and your family. There are many reasons why individuals with an ID are more vulnerable to becoming infected with COVID-19 and more vulnerable to adverse outcomes from this virus. These include the significantly higher prevalence of comorbidities such as respiratory diseases, obesity, and diabetes that are associated with worse COVID-19 outcomes, as well as immune system dysregulation among individuals with Down syndrome and the high occurrence of living in congregate settings such as group homes. Mark and colleagues 2020 found that household size was a significant predictor of mortality. Using the household size of 1 as a reference value, relative hazard ratios for household size were 1.47 for 5 to 8 people and 5.08 for 9 or more people. Reasons for these high RHR values among people with ID include the difficulty of isolating people who have tested positive for COVID-19 and because some individuals need assistance with activities of daily living. So it is perhaps not surprising that data from the first wave of COVID-19 demonstrated that among individuals with an ID, case and incidence rates were generally higher than rates among individuals without an ID. For example, as you can see in the forest plot that I've created from international data adjusted for sex, age, socioeconomic status and comorbidities, individuals with Down syndrome were significantly more likely to test positive than the general population, and higher than comorbidities such as obesity. Consistently, case fatality rates have been significantly higher among individuals with an ID. In addition to mortality and morbidity associated with SARS-CoV-2 infection, the pandemic has other deleterious outcomes for people with an ID. People with ID and their caregivers report adverse effects on mental health, including feeling confused and stressed because of the vast amounts of COVID-19 related information and disinformation, as well as the loss of respite care that can afford them breaks and support their mental well-being. Other adverse outcomes were disruption to work, study and daily routines, loss of healthcare services, deterioration of social skills and the loss of what has been learned, and feeling disconnected from family and community. In South Korea, parents of adult children with an ID felt their children were losing vitality, gaining weight and were inactive, particularly during lockdowns. Similarly, 61% of parents of children and young adults with physical and/or intellectual disabilities in the UK reported a reduction in physical activity and fitness of their children during the pandemic. And parents of children with autism spectrum disorder in Turkey said their children were becoming more sedentary and their motor skills were deteriorating during the pandemic. On a brighter note, emerging evidence shows that many individuals with an ID are able to successfully engage in preventive health strategies, comply with healthcare staff and public health guidelines, and adapt to the lifestyle changes resulting from pandemic responses. Experience of both large and small contexts have shown that many individuals with ID are able to successfully engage in health behaviours such as isolating in their room when infected, hand sanitising and wearing a mask. In Spain, Navas and colleagues 2021 found that 52% of people with ID in their sample of 582 provided emotional support, recreational support such as planning activities and spending time with others, or instrumental support such as doing chores or the shopping for those they lived with. This helped those they live with manage better during the lockdowns. Second only to contact with family and friends, Navas and colleagues also found that recreational activities was what was missed the most by participants during the pandemic. Among 22 to 44-year-olds, 53% of those living in congregate settings and 44% of those living on their own or with family missed recreational activities. This change in access to recreational activities was also evidenced by Jeste et al. In 2020. These authors reported that 89% in the US and 87% outside the US of individuals with an ID had lost access to face-to-face recreational services, and only 11% in the US and 13% outside the US had acquired alternate access to recreational services such as online. As such, it is not surprising that a survey of priorities among 29 organisations serving people with ID in the United Kingdom highlighted the need for exercise opportunities during the pandemic. Special Olympics is an organisation that serves the recreational and sporting needs, and more, of individuals with intellectual disabilities. Special Olympics is a global organisation that provides year-round sports training and competition for children and adults with an intellectual disability and unified partners without an intellectual disability. Founded in 1968, Special Olympics operates in 200 countries and jurisdictions worldwide, encompasses more than 6.7 million athletes and unified partners, 1 million volunteers, and more than 500,000 coaches. With the support of more than 1 million coaches and volunteers, Special Olympics delivers 32 Olympic-type sports and over 100,000 games and competitions throughout the year. I have coached and volunteered with Special Olympics for a long time, primarily as the head coach of my young athletes programs at the University of Victoria. In Canada, we have 2 young athletes programs tied to our national long-term development framework: the Active Start program for 2 to 6-year-old children and the Fundamentals program for children aged 7 to 12 years. As the head coach of those Special Olympic programs, I have mentored many undergraduate and graduate students into the roles of volunteers and coaches. I also present for Special Olympics Victoria and Special Olympics BC when they ask me to. As a researcher, I have worked with many Special Olympic athletes locally to investigate aspects of athlete health and fitness. And I have worked with Special Olympics Canada to help evaluate their Coaching Young Athletes training program. I have been very fortunate to work with the marvellous Doctors John Foley, Megan Lloyd and Pauli Rintala on secondary data analysis projects with Special Olympics International Healthy Athletes, Fun Fitness and Health Promotion databases. Like much of the world, the programs I coach have been impacted by the Covid-19 pandemic. This is an image of 2 boys playing floor hockey in our Fundamentals program. Unfortunately, we had to cut our 2020 season short when the university closed, and we have not been face-to-face since March 2020. We are hopeful that we'll be able to resume in September this year, and that will be an absence of 18 months. To help the Special Olympics community during the pandemic, Special Olympics has developed new resources and utilised existing resources in slightly different ways. There is a lot, most of which is available to everyone on the Special Olympics website. There are resources such as videos to show participants how to and videos to exercise with, resources to inform the Special Olympics community about COVID-19 and vaccinations, return to activities protocols and the associated training through the online learning portal and on the website, ideas for virtual games and resources to support health. Many of the resources created specifically to help with the pandemic are available in several languages. For example, the infographic on the left about COVID-19 symptoms, transmission and protective measures is available in 5 languages. The Staying Fit at Home calendar in the middle utilises existing Special Olympics Fit 5 resources in a new way, creating some structure for at-home workouts supported by videos and fitness card, and encouraging athletes to connect with the health messengers. Resources have also been developed for young athletes and their families, including linking to agencies with tips on how to talk about coronavirus with children, activity carts for families, and video follow-along sessions. The Special Olympics Return to Activities protocol spans 4 phases, from Phase 0, where stay-at-home orders are in place, to Phase 3, where there are no restrictions on gathering size and public facilities are open. The protocol indicates that virtual programs should be offered in each of the phases, and it acknowledges that timelines for returning to these phases by local programs will vary. The graph shows some data from the October 2020 Special Olympics Covid-19 survey, when most programs were in Phase 0, the stay-at-home phase. As you can see, at that time, 54% of all program respondents and 73% of North American programs offered online health and fitness programs. Approximately 1/4 of all program respondents were offering offline programs during this phase. I can't talk about all of the program offerings. As I said, there's a lot. But it certainly seemed to me that Special Olympics had, to use a baseball metaphor, stepped up to the plate. I'll use Fit 5 as an example. Fit 5 was developed prior to the pandemic to help programs expand their fitness programming and initiatives. The guide, videos and cards were designed to be utilised with flexibility, giving programs the opportunity to integrate and implement the resources in a way that aligns with their current goals and objectives. These resources have been utilised during the pandemic for at-home fitness work. In my local chapter, which is the province of British Columbia, Fit 5 resources were used in an interactive calendar that would take each athlete to strength, endurance, flexibility, healthy eating and other health challenges during December. Each one of the icons in the calendar linked to a video or written resource suggesting activities and actions for that day or in general. For example, that apple icon linked to how to prepare overnight oats. The uptake of the resources is somewhat less clear than what has been offered. From the Special Olympics October 2020 survey, we know that approximately half of the responding programs were offering virtual programming and 1/4 offered offline programming. However, as Dr. Jamie Vallis said in our Zoom chat, those connecting digitally tended to be the same athletes, and the creation and delivery of online programming is associated with wealth. Recognising and meeting that need, Special Olympics Africa translated the Fit 5 program onto printed cards that were used by athletes and coaches who did not have access to online resources. Back in my neighbourhood, there have been considerable efforts to connect with athletes virtually that link to both community resources and Special Olympic resources such as Fit 5 and the School of Strength. These efforts have included Facebook Live sessions to try and connect in a more personal way. Still, the uptake is somewhat unclear as the resources are freely available, but estimates from numbers joining virtual activities suggest that approximately 15% of athletes have connected at this chapter level. For example, looking at the registration for our virtual provincial challenge games, which are underway now, you can see that 650 athletes and 200 coaches are participating. Our usual numbers are 5,000 athletes and 4,000 volunteers and coaches. So this is about 15% of our usual athlete numbers. Because we know that athletes who train during stay-at-home orders have more assets in terms of returning to activities, it is very important to think about who has not been participating as we transition back to in-person programming. As Alex, who has been training during time away from face-to-face training, tells you in the video you're about to watch, virtual programming has been better than nothing, but he's really looking forward to getting back to competing.
My name is Alexander Contrivaro. I am 39 years old. I am a Special Olympian. I play soccer, basketball, for hockey, snowshoeing, track and field, softball, bocce ball. Feel bad why I can't compete with my friends, teammates, and training every day. I miss snowshoeing and being with people like my friends, my teammates. I do online stuff with Special Olympics to keep in shape. It's real different, but it's better than nothing. When COVID done, I can't wait until completing again. I want people to know I never give up. I am confident in myself and I don't give up.
I now want to share with you some of what is being done regarding return to activities and sport, including concerns people have about post-pandemic life, data Special Olympics International collected about people's concerns, a story about Special Olympics New Zealand's transition back to sport, and several issues that we need to think about as we return to activities. In a recent letter published in the Canadian Medical Association Journal, Costello and colleagues argued that the risk of transmission of SARS-CoV-2 needed to be balanced against the adverse physical, social, and mental health outcomes of not participating in physical activities. These authors stated that efforts to mitigate the collateral damage caused by pandemic control measures should focus on safe return to sports and recreational activities. To that end, government agencies, expert task forces, and sporting organisations have developed return to sport and physical activities policies, guidelines, and resources for the general population, for those who have recovered from Covid-19 and for people with disabilities. At their base, these guidelines are informed by local public health mandates and are periodically updated based on community prevalence of Covid-19 and conditions on the ground. Special Olympics International has also developed a return to activities protocol, which will supplement mandates that apply in each program's context. The protocol provides the minimum guidelines for Special Olympics programs as they consider returning to activities, and includes a broad range of Special Olympics participants and functional areas such as sport, schools, healthy athletes, and leadership. The protocol describes the type of activities that may be offered by Special Olympics programs during stay-at-home orders, as well as in 3 phases of return to activities. The protocol provides details of mitigations and precautions to be taken in each phase, including details of compliance, necessary education, preparation needed, and measures to be implemented at the activity. This extract from a Special Olympics video resource shows a measure being taken at an activity.
During practice, it is important to maintain physical distancing of at least 6 feet or 2 meters between all participants. To do this, place markers on the ground to indicate what 6 feet is and have extra volunteers to remind participants to maintain their distance.
Special Olympics International has developed many resources to help with the return to activities. These resources are available both on the website and through the Special Olympics online learning portal. Understanding people's willingness to return to pre-pandemic activities is a burgeoning area of social science research. For example, a recent survey of 4,885 United Kingdom adults revealed that people held very different positions in terms of their willingness to return to pre-pandemic life. Allington and colleagues' cluster analysis produced 3 distinct groups, who the authors labelled the keen, the concerned, and the content. The keen were 52% of their sample. They had few, if any, concerns and were keen for normal life to resume. The concerned were 34% of the sample. They were reluctant to return to normality. The content, at 14%, were a smaller portion of the sample. They would prefer to keep things as they are, such as working from home. The study asked many questions, but differences between these groups are exemplified in their responses to the 2 questions you can see here. For the first question, 8% of the keen and 48% of the content indicated that concerns about catching COVID would stop them returning to pre-pandemic activities. Now for the audience participation part of this slide. Take a moment to consider what proportion of the concerned feel this would stop them. It was 79%. Were you close? You can see dramatically different responses in relation to the second question as well. This research from the Policy Institute at King's College London tells us that return to some level of normalcy will involve considerably more at the person level than just lifting restrictions. Identifying the concerns of participants, caregivers, families and staff about returning to activities will help with the transition back to engagement by tailoring supports provided. Special Olympics International conducted 3 international surveys during the pandemic, and I very much want to thank Ulia Mihaela, the Senior Manager, Research and Evaluation at Special Olympics, for sharing some of these findings with me for this presentation. The second and third surveys sought some information about challenges of returning to activities. Participants in the second survey were 239 Special Olympics program health staff. The graph shows you the percentage of respondents reporting challenges at the program level. Common challenges were not feeling comfortable, difficulties securing venues that meet COVID-19 criteria, worries about participants following physical distance guidelines and conducting on-site screenings, as well as access to adequate personal protective equipment. The experience of Special Olympics New Zealand has particular salience for return to activities. I want to especially thank Carolyn Young, the Chief Executive of Special Olympics New Zealand, for sharing her insights on the New Zealand experience. New Zealand has a 4-level alert system for COVID-19, from Alert Level 4, Lockdown, where the disease is not contained, to Alert Level 1, Prepare, where the disease is contained. In Alert Level 1, there are no restrictions on personal movement and sports and recreational activities are allowed. While in Alert Level 2, participation in sports and recreational activities is allowed, with some restrictions on gathering size, record keeping for contact tracing, hygiene requirements and physical distancing. Special Olympics New Zealand staff developed protocols and opportunities for participation during Alert Level 2. However, New Zealand's Special Olympics community didn't want to return to activities until Alert Level 1 was reached. So that's what they did. And except for a few minor interruptions, Special O New Zealand has been running their program since June 2020, which means they only had a 4-month-long interruption. This Special Olympics New Zealand experience, where the community was only comfortable returning to activities when the disease was contained, suggests that athlete, volunteer and coach concerns about transitioning back to sport may be more deep-seated in countries with much longer absences from sport. Special Olympic New Zealand's exciting news is that they are holding their National Summer Games in December. It is quite inspirational to hear that this big event is taking place. However, despite being back to near usual programming for a year, COVID plans are still in place. If New Zealand's alert level changes from 1 to 2, a large gathering such as this couldn't take place. So Special O New Zealand has to plan how to get athletes and volunteers home safely if alert levels change. There are several other things for us to consider as we return to sport and physical activity programming. These include hesitancy amongst the vaccinated, re-engaging, loss of skills, fitness and confidence, and post-infection return to sport. As vaccinations are being added to the public health response to COVID-19, albeit at different rates around the world, there is hesitancy to return to activities even among the vaccinated. The published research in this area is lagging behind, but investigative reporters have suggested that people feel there is much to learn still about vaccinations, including not knowing how long the vaccine is going to last and breakthrough cases. So even the vaccinated may be hesitant to re-engage. Although the Special Olympics International surveys with athletes found that 71% of athletes had utilised at least one Special Olympics resource and 75% had been in contact with someone from Special Olympics, disconnection from organised sports and physical activities is of concern. Reflecting on their qualitative findings of the impact of Covid-19 on youth sports in South Australia following the end of the first wave of Covid-19 restrictions, Elliott and colleagues 2021 identified re-engaging participants and volunteers as a substantial problem. This concern was also expressed by staff at the British Columbia chapter of Special Olympics. Helen Chung, Sport Manager, Special Olympics BC, said, "We've lost connection with a lot of them, although our key volunteers have stayed involved throughout this. Thus, a priority of Special Olympics BC as we transition out of the pandemic is rebuilding programs, numbers, bringing competition back and reconnecting with the more transient volunteers such as university students." Elliott and colleagues also found that some youth did not keep fit or practice during the pandemic, which was also associated with a decrease in confidence and self-efficacy toward re-engaging with sport. Evidence among people with ID during the pandemic of lower levels of physical activity and exercise, fewer recreational activities, weight gain, adverse effects on mental health and regression of motor and other skills suggests that careful attention is needed for the reintroduction of sports and physical activities. This re-engagement should include conversations about what participation did occur during the pandemic, because we know that athletes who train during stay-at-home orders are less anxious, perceive more control, and were more intrinsically motivated to return to sport. The graph you see is from data collected for the January 2021 Special Olympic Athlete COVID survey. It shows that 18% were already engaged in in-person health and fitness programming. As this number grows, we need to attend to both the physical and emotional needs of athletes. This is something that Special Olympics New Zealand emphasised after only a 4-month hiatus. Initially, coaches were urged to focus on athlete well-being and fun rather than performance. Returning athletes to sport training and competition following a COVID-19 infection is a burgeoning area of research and clinical commentary. There are emerging concerns about the chronic damage of COVID-19. The earliest published advice by Elliott and colleagues in 2020 provided a graduated return to play protocol post-infection for those with mild or moderate symptoms. The 6-stage process provides characterization of the type of activity and exercise, recommendations for duration of training and percentage of heart rate maximum while training, the objectives of training and athlete monitoring, and psychological readiness for return to sport is included in all 6 stages of the guidance. The authors note that athletes who have been hospitalized for COVID-19, who have complications or prolonged illness, or who have comorbidities such as cardiovascular disease, should have further medical assessment before returning to play. These guidelines have been adapted for children and adolescents by the American Academy of Pediatrics. Currently, the Special Olympics International Return to Activities Protocol has a statement: if participants have tested positive and or been diagnosed with COVID-19, the participant must provide written proof of clearance from their healthcare professional prior to returning to sport or fitness activities. Further to this, I think we may want to consider what proof of clearance may actually mean and how coaches should proceed when proof of clearance is obtained. I have cited 34 papers in the manuscript I've written associated with this presentation, and every single one of them was published in 2020 or 2021. However, as the co-editors-in-chief of the Disability and Health Journal noted earlier this year, Data-driven articles are much needed to support the health interests of people with disability in health policy. This is a rough breakdown of the literature I've cited in my article. As you can see, 6 focus on epidemiology, 7 on the experiences of the pandemic by people with intellectual disabilities, 6 on clinical management of COVID, 2 on return to activities guidelines, and 2 have a direct focus on physical activity, and to date there are none on post-pandemic concerns. Not surprisingly, most of this work is from the first wave of COVID. So I think there is a need for research related to COVID-19 and Special Olympics. In particular, the issue of re-engaging post-pandemic has captured my attention. For example, how do groups within the Special Olympics community feel about re-engaging? What are their concerns? In what ways could a model such as Allington and colleagues, the keen, the concern and the content, help us understand post-COVID intentions and return to activities? Who among Special Olympics actually re-engages and who doesn't, and why, and what can be done to help them reconnect? I'd also be curious to know whether the length of absence from face-to-face Special Olympics activities predicts challenges of re-engaging. And are these challenges ameliorated by engagement with Special Olympics or alternative physical activity programming during the pandemic? What are the levels of athlete self-efficacy towards re-engaging with Special Olympics? And what's influencing those levels, for example, the loss of skills or fitness? An area of clinical and sports medicine concern is return to sport after having a COVID-19 infection. It would be useful to know what proportion of returning athletes have had a COVID-19 infection, how severe was their illness, and whether there was chronic damage of COVID-19 such as myocarditis. Relatedly, who is monitoring their return to sport? For those who have recovered from COVID-19, athletes, coaches, and volunteers, what is their psychological readiness to return to activities? Does psychological readiness to return differ between those who've had a COVID-19 infection and those who have not? This journey into COVID-19 and Special Olympics started for me with an aside comment from Molly Sadowski as I was getting background information on the Fit5 program. Molly mentioned that those resources have been particularly helpful during the pandemic, so that was it. I was off on this journey. I've learned that COVID-19 has had a disproportionately negative impact on individuals with intellectual disability, on their physical health, mental health and emotional well-being, on aspects of functioning and on lifestyles. Perhaps even more than most, they miss recreational activities. I have found that Special Olympics has, using that baseball metaphor again, stepped up to the plate. A myriad of resources have been created or reimagined. I believe the transition back to normalcy needs care and attention. For some, this transition will not be problematic, but for others it will be. The Special Olympics community needs support through the transition and to learn from each other as we do so. I wish to express my heartfelt thanks to the members of the Special Olympics community acknowledged on this slide who have shared their insights and pandemic experiences with me, and now with you. Thank you.